Okay, and it looks like we are 2 past the hour, so we can begin. Hello, and thank you all for joining our August MMS info session. These sessions are offered under the CMS Measures Management System contract led by Patel. I am Kate Buchanan, and I support education and outreach efforts on this project, and today's session is on the Gravity Project. So we can move to the next slide. These info sessions are part of an ongoing effort to engage measure developers and other stakeholders in quality measurement topics. And before we jump into today's topic, I do want to cover a few housekeeping items. First, today's session is being recorded. Second, all participants will be muted during the call. You can enter your questions in the Q&A feature. We will have an opportunity for Q&A at the end of the call, but I encourage you to submit questions throughout the presentation. If you are unable to see the Q&A panel on your screen, it is to the right bottom. You will see 3 dots. If you click on that, you should see the Q&A feature. So that's how we'll ask questions. Finally, throughout the meeting, we will share resources in the chat window, which is above the Q&A window. You should see the link for today's slides. So there are a couple of things that we will reference throughout, and the chat function is where you will get the resources. The recording of today's presentation will be posted to the CMS YouTube page at a later date, and I am now going to turn it over to Evelyn Gallego. Evelyn?
Thank you very much, Kate, and good afternoon, everyone, or good morning for those on the West Coast. So I'm delighted to join you today to speak about the Gravity Project. I'm Evelyn Gallego, currently serve as the Senior Advisor for Gravity. I'm also the co-founder of the Gravity Project that we've been working on for almost 5 years now. And with me today is Dr. Sarah DeSilvi, who serves as our Terminology Director. Both her and I will be presenting, going back and forth, so you'll hear both of our voices throughout. But I'll kick us off, so if we move on to the next slide. So our quick agenda always begins on the why. We start why we're doing what we're doing and the value it has for the industry overall. We'll talk through on this our scope and our accomplishments, our what, and then Sarah will carry us on a deeper discussion on alignment of our work to national quality measures work. And then I'll end on how to engage, right? So how you can participate in various efforts and how this work also aligns with different at the policy and program level. Next slide. Great, so let's start with acknowledging, we are working on a data standards project. We're creating common language for social risk factors. So it is important that we ground ourselves on an SDOH lexicon, especially as more and more of these terms are being used interchangeably. And I will note that our team is currently working on a blog post to bring more clarity to this as we're hearing different uses of the term. So just here to ground us at a systems level, we have health equity, which is achieved when every person has the opportunity to attain his or her full health potential. As part of health equity at a community level, we have social determinants of health, which are defined by the CDC as the conditions in which people are born, grow, live, work, and age. SDOH is further defined at an individual level as protective factors, social risks, and social needs. What's important here is that SDOH is neither positive nor negative. They are attributed to protective or positive factors and social risks, and they are acted on by patient-identified and prioritized needs. Under the Biden administration, health equity has been front and center. It is important to note that addressing SDOH is a primary approach to achieving health equity, but it is not the only means. For instance, health equity is advanced with improvements in access and quality of care as well. Next slide. So why are social determinants of health important? There is growing awareness that unmet social needs negatively impact health outcomes. We know that over 50% of our overall health is driven by socioeconomic factors and the physical environment. We know unmet social needs negatively, as I mentioned, impact health outcomes, and COVID has only magnified this as we are seeing and hearing and learning more about increasing health disparities as a result of these unmet social needs. We have growing evidence that food insecurity correlates to higher levels of diabetes, hypertension, and heart failure. Housing instability factors into lower treatment adherence, and transportation barriers result in missed appointments, delayed care, and lower medication compliance. Next slide. So even if we can all agree that addressing SDOH, social needs, social risk are important as we strive for health equity and whole person care. Challenges still remain on how to capture and exchange this type of data across clinical and social service systems. The Gravity project, which I will introduce next, only addresses the two challenges, primarily addresses, I will say that, the two challenges you see here highlighted in red: the standardization of this data for collection and storage and exchange, and sharing it across ecosystem parties. There are still other challenges, some of them listed here, that still need to be met and addressed across the industry. Next slide. So this brings us to what the Gravity Project is. It is a collaborative public-private initiative launched in May of 2019 with the goal to develop consensus-driven data standards to support the collection, use, and exchange of individual level, as we say, social determinants of health data. Next slide. Our scope is primarily to develop data standards. Really important as we go through this discussion that there's many thoughts that Gravity does many things, but really our primary focus is developing data standards to represent and exchange patient or individual level data documented across 4 clinical activities of screening, assessment, diagnoses, goal setting, and treatment and interventions. As part of our data standards work, we also test and validate this data for use not only in patient care, but also to support care coordination between health and human services sectors, for population health management, for public health, value-based payment, and for clinical research. To date, you will see, I know the icons are very small, and Sarah will speak to this at a deeper level. We've completed 17 domains, social determinants of health domains, as listed there. These have been grounded by those included in the National Academy of Science, Engineering, and Medicine 2014 report on capturing social and behavioral domains. They're also now very much driven by Healthy People 2030 domains. Next slide. We do our work through 3 active work streams now: terminology, technical, and pilots. The terminology work stream that Sarah will speak to very primarily focuses on developing the domains, the data concepts, submitting for new codes, and more importantly, developing and publishing the coded value sets in the National Library of Medicine, Value Set Authority Center. In parallel, we also have a technical work stream working on the FHIR standards, FHIR specifications. So, and right now I'll give an update of where we are with our FHIR specification. We also at the same time have a pilots work stream where in the process we will launch officially next month that is focused on testing and validating both the terminology and the technical standards. Next slide. We do all our work by convening a very large public collaborative of now over 2,500 participants from across the health and human services ecosystem. These include entities that participate not only from clinical care or health IT vendors, but it's community-based organization, it's public health, it's research, it's academia, it's health plans. We have many we have associations. So this is really representative of all those that need to use the data. And it is our ability to engage and collaborate across these diverse stakeholder groups that truly sets us apart as a standards-based project. And again, we are often recognized for our ability to actively strive to achieve consensus across all these groups. We do have 2 active, let's see, where our work streams are facilitated through a terminology. We have a public collaborative that meets bi-weekly. Right now, I will acknowledge that it's on pause as we work to fundraise for kicking off a new domain. But once this is up, we will continue. Again, this is just a pause. We did have a break, a purposeful break in the summer with a plan to launch in September. Right now, that will be delayed for hopefully not too long. But at the same time, we also have a technical work stream facilitated through the HL7 patient care work group where we develop and review the FHIR implementation guide. Next slide. The Gravity Project is not an entity, and we're a project funded by multiple organizations through in-kind and financial sponsorship. So for that reason why we are currently fundraising to be able to kick off our new domains and work for next year. But it's very important to acknowledge that we do receive support from the federal government, including CMS, ONC, ACL, the Administration for Community Living, ARC, and the CDC. Their contributors are health systems, private payers, philanthropies, and technology vendors. Next slide. So quickly, our timeline as a project began in 2017 when the Social Interventions Research and Evaluation Network out of UC at University of California in San Francisco, SIREN, they convened over 50 individuals from across the health and human services sector in Washington, D.C. to discuss a problem they had identified as part of their research. And the problem was the lack of codes available to represent social risk data in electronic health records. So we launched the Gravity Project in May of 2019 with funding from the Robert Wood Johnson Foundation and focused on developing data sets for food insecurity. And that's where Dr. Sarah DeSilvi led. She was our food insecurity expert. In August of 2019, the Gravity Project became an HL7 FHIR accelerator project to ensure that our work helped to advance the use of the FHIR specification for health data exchange. In 2020, we shifted from working on one domain at a time to working on multiple domains at a time. In 2020, we also began our work on the HL7 SDOH FHIR implementation guide and began testing it at the HL7 FHIR Connectathons. Last year, we published data sets and completed code submissions for 11 domains. We also published our first FHIR implementation guide as the standard for trial use version 1. And most important, our data sets were included in national policy as data classes in the U.S. Core for Data Interoperability, or USCDI version 2. This year, we've primarily been focused on dissemination and testing of the work. So that's why we're very excited, and I'll announce the launching of the pilots Workstream. Next slide. Here's our deeper look at our roadmap for this year. We are now, we're in close to the end of August. We completed 3 domains this year. So health literacy, health insurance coverage, and medical cost burden. And then we spent the summer, as I mentioned, purposely taking a break, and Sarah will speak to this process that she has with her work stream. In the fall, we had proposed to kick off 3 new domains: digital and equity, neighborhood safety, and food access. As I mentioned earlier, those are on pause right now as we work to fundraise. Our FHIR work continues. We are on target to publish a version 2 of a FHIR implementation guide. So that will be published next month. And then there'll be updates made to 8 Best on the pilots. And the pilots, we officially kicked them off September. I think it's September 24th, 27th. We submitted these slides before we had the final date announced. Next slide. I believe now I hand over to Sarah.
Thank you so much, Evelyn. It's my honor to be here today. I come to you from my rural family practice clinic in Vermont. So I apologize if there's any audio concerns. I'll do my best to speak slowly and clearly. Again, I'm the director of the Terminology Workstream. I'm going to be talking about the Workstream in particular. And I also lead our intersections with quality measure development and value sets, of course. So we'll be touching upon that in the next minutes as well. Next slide, please. Evelyn spoke to the 3 different work streams that we have. I'm going to do a deep dive again into terminology, but before I go into this slide, I want to talk a little bit about a piece we haven't really called to light yet. We have an amazing public collective, 2,500 plus individuals from all kinds of different backgrounds who come to help us develop these data standards and make sure we have different stakeholder perspectives. We have intentional representation on our governance committees too, so we make sure that we balance patient, community, clinician perspectives. Another piece in there that is not on the slide, so this is why I'm pausing for a second, is the grounding of every single one of our domains in a technical expert panel or subject matter expertise. So for every domain, whether it be food insecurity, medical cost burden, or health literacy, we ensure that we're developing our data standards and choosing the screening tools and defining and clarifying diagnoses in alignment with the literature. So for each different domain, we convene a technical expert panel on that domain to help guide us. The great thing is that voice of that technical expert panel is a weight against the collective just to make sure that everything is balanced. And again, that's how I came to the project originally, was as a food insecurity subject matter expert who happened to be a terminologist. So the accomplishments we have so far within the terminology workstream were quite vast. So I'm going to we build across these 4 different core activities that are really based on clinical and social care practice. So the activity of screening, which is using standardized tools or screening tools for screening. The activity of diagnosis, or defining problems, social risks, assets. The activity of setting patient-centered goals, and the activity of intervening. So for each domain, we build sets of data across those 4 activities. So over the course of our few years, we have completed code submissions for 17 social determinants of health domains. We've developed multiple screening tools into LOINC terminology, which ground our screening and assessment collection. We've clarified and specified ICD-10 Z codes for 12 domains, which is hopefully going to help increase uptick, because if you have a clear term to define that a patient is housing unstable or food insecure, as a clinician, it helps drive the use of that term. And I can say that from personal experience in rural Vermont. We've worked very closely with our colleagues at SNOMED CT, both on problem list codes and intervention codes. But notably for this presentation, I want to focus on the fact that we have published 123 value sets in the National Library of Medicine that again align with those 4 activities. So we are the steward and curator of these value sets for NLM and the ONC. Each of those value sets are either broad social determinants of health value sets that include everything that we've done just for reference across all of our domains, but they also dive deep down into every specific domain. These value sets that are grounded in the technical expert panel, that are built into code, and that are vetted by our broad stakeholder community become the ground for our work with our quality measure development friends across the ecosystem. And of course, as Evelyn mentioned, we were included in ONC US CDI V2. Next slide, please. An example of some of the terms that we've built specifically for food insecurity, my origin story, is building terminology for the hunger vital sign, building terminology both for the problem list code of food insecurity, but specifically for the ICD-10-CM code for food insecurity, which came out last year, building patient-centered goal statements, and then really building critical interventions. And when we think about any kind of screen and intervene measure, these are the core for any kind of approach to an intervention aligned with the literature. So we, again, reference the literature both for critical and necessary programs, services, products that are aligned with that domain. And then we build that terminology into SNOMED. We also have taken great pains to ensure that the critical roles of social care are represented in our interventions. You can see that in, for instance, the referral to community health worker. We know lay people, the community health worker, and community-based organizations are really critical within medical and social care integration. So as we're building terminology, we're very, very careful to ensure that the voices and roles and labor of our community friends are part of our terminology approach. Next slide, please. Part of our work in terminology and development for social risks is, of course, defining everything. So we had to define our approach to building intervention terminology by grounding everything in common definitions. So this is the framework we use for our intervention build. I want to call out new types of interventions and activities that didn't exist in terminology prior to our work, notably coordination, which again, when we think about the role of medical and social care integration, there's a lot of coordination of care plan and coordination of resources that goes on in the social care space. So prior to Gravity, there was no coordination term. So we built that term and aligned it with the AHRQ definition for coordination. And that term is throughout our social risk value sets at this time. Next slide, please. We also have a lot that we still are thinking of doing. We are very focused on addressing minority strain discrimination and bias. We hope to achieve that and address that with our technical experts in the winter of 2023, combined with addressing ACEs. At that time, that would be our approach. We know we have to address green space, expanded material hardship elements, incarceration, migrant labor, and then, as Evelyn did mention, we based a lot of our work on Any Healthy People 2030 or Biden administration objectives and priorities. We also have different activities we're working through, accounting for care, whether it be social care, CPT, or Category 2 codes to assist with value-based healthcare arrangements, and HCPCS codes. And these are all for enhancing quality, evaluation, and value-based partnerships. We work with our social care taxonomy friends, such as 211LA and AIRS, to ensure that we're aligned and mapped and mirrored in our approach to terminology development. We're working and considering how to approach sharing information on eligibility and enrollment. And we participate in quality measure development to lend our insight and terminology expertise to that work. Next slide, please. I wanted to specifically call out some of the things that we think of intentionally in our building of our value sets and VSAC when it comes to quality measures. So this is on the next slide. Next slide, please. So I mentioned on the slide a few slides previous about the VSAC value sets that have curated sets of data across the 4 activities of screening, diagnosis, patient-centered goals, and interventions. So within those VSAC value sets, Gravity is considering from the get-go all kinds of different approaches to quality measure development that would be possible within those different sets. Whether the intent is to just screen to develop capacity, whether you're doing a screen and positive rate to, again, build on capacity building and do population level risk assessment, whether you're mirroring existing HEDIS measures for depression screen and intervene, and you want to do capacity building plus intent to assist. And there's also, we consider intervention success and social needs met, such as considering how to do connection to services, not just within our terminology, but within our implementation guide. Patient-reported satisfaction, again, not just within terminology, but considering how to do that within our implementation guide. And then we also do consider and anticipate measures that might do a reduction in severity, but these would, of course, depend on the quality and breadth of any of the initial screening methods. This would be akin to other remission measures, such as the depression remission measure. But all of that capacity and that intention is built into our value sets and our approach and the curation of screening tools and diagnoses that we have within our work. And of course, because we are a data standards development project, we are always eyes on the prize with ensuring that we're aligned with digital quality measures. So that is the anchor of our work in developing the VSAC value sets. Next slide, please. I think, Evelyn, I'm passing the mic on to you.
Thank you, Sarah. So I'll quickly go over our other 2 active work streams. So next slide, we're starting with the technical. So we do want to acknowledge the in-kind support, as I again mentioned earlier. We are very grateful for the entities that support us and provide resources to lead and advance our work. So our technical work stream is currently sponsored by New Wave and the American Medical Association. Next slide. So we have a FHIR implementation guide that the first version was published last year, a year ago. The FHIR IG supports the exchange that I always make a reference of a FHIR IG serving like a container to allow the exposure and the movement of the data. So right now it supports, aligns very much to every new domain created and supports all the activities. We mentioned assessments, but it also incorporates health concerns, problems, goals, consent, aggregation for exchanging or reporting the data, also exchanging with patient or client-facing applications, and it does include draft specifications for race and ethnicity exchange. So we're in the process of publishing our currently tested FHIR IG in September following the HL7 process. Next slide. And this just does a deeper dive on what the FHIR IG supports, the use cases. So very much aligns to the activities that Sarah walked through on the terminology side and supporting the use of this data. So the first use case very much is about documenting the data, the SDOH or the social risk and social needs data or social risk data as part of the patient encounter. And this is where you define the health concerns and the problems. The second use case is around defining the patient and provider SDOH related goals, which would say this is where the social needs come in as defined through the goal setting. The third use case is taking action on the problem identified and the goals, right? So use cases around planning or communicating and tracking related interventions to completion to include what we call closed loop referrals. The fourth use case is measuring the outcomes of these activities. The fifth one is around establishing cohorts of patient with common SDOH characteristics for use beyond the point of care. So this is really the ability to aggregate the data for upstream use for population health, but also downstream for quality reporting. So there is an activity that allows what we say using the bulk FHIR resource to be able to aggregate and then use the data for other purposes. Next slide. We did have a recent Connectathon, so it's really important. As I said, our work is defining the data standards and testing them. So we've had several Connectathons, FHIR, and participate. This was our second CMS Connectathon. So I just want to acknowledge these organizations or these entities came to test, both very much focused on having the closed loop referral and the assessment, so the screening activity, as well as the intervention specifically focusing on the referral intervention. The second, there were some entities that also incorporated race and ethnicity data and SOGI data exchange, which are not, again, they're not gravity data. They're not being defined as part of the gravity project, but through other HL7 projects. Next slide. So what are technical activities under consideration? Sarah walked through what we have for terminology. On the technical side, we've proposed to define and identify methods of an anonymization of data to support the reporting for public health. So this is where de-identified data is appropriate. There's lots of discussion on that right now. We've also proposed to develop new use cases and requirements for aggregation and de-identification of SDOH information for population health and research. The third area is also to develop or incorporate new use cases that can be supported by the existing FHIR implementation guide. So I mentioned our work has been very much grounded on data being captured within the electronic health record. These are clinical activities, but we hear from our community there is also a need to define the data exchange between one community-based organization to another. So that's a potential use case, as well as a community-based organization to a state agency. So we know these are activities that are happening in the field right now, but they're not using standards-based approaches. Next slide. All right, pilots, next slide. So we're really excited to formally announce that we are kicking off our pilots Workstream in September as monthly webinars, and our work is sponsored by the Office of the National Coordinator, the Administration for Community Living, AARP, and recently we just added the IHE that is part of HIMSS. IHE USA is also supporting our work. Next slide. So when we kick off, we'll introduce our approach, but we've very much been centered on meeting all our implementers where they're at, meaning that we do not expect everyone who comes to want to test to be FHIR enabled. We know overall there's a lot of change right now, and I know the rules help create the incentive for adopting FHIR, but a lot of the entities we work with are not regulated by CMS. And therefore do not have those incentives in place. So we want to be able to support all levels of standards testing. And so we've created a tiered approach to testing and implementation. It allows entities with limited health IT standards adoption to reach the attainable milestones during the piloting phase. So, and entities can participate in any of these, but at a high level, the tier 1 is really where we focus on terminology. So we say these are the minimum requirements. We are not talking about exchange. We are not specifying the content or the transport standard, but really tier 1 is really to validate the coded terminologies as developed through the terminology workstream, but it also incorporates some identification of workflow that needs to be changed, but there will be no data moving as part of tier 1. But that's still significant feedback because as I mentioned, we have 17 domains we've completed to date, and no one's been formally testing them out in the field. The second tier just brings again, these are incremental. It's really building on existing data infrastructure. So this is where the folks already using, we work really closely with folks that have adopted 360, IHE 360X as an example for closed loop referrals, or exchanging via CCDA and direct. So this is an opportunity for them to incorporate the coded terminologies. And then the last year is the full FHIR exchange, being able to have a FHIR endpoint, exposing your data or being able to query it using FHIR. Next slide. So we're actively calling entities to join us. So it's testing the coded concepts as well as the coded terminologies, coded concepts in the FHIR IG. We're standing up the FHIR, the Pilots Affinity work group, and we're asking folks to submit their interest. So far we do have some pilots that will serve as the example. So if we move on to the next slide, we want to acknowledge that we do have funded pilots right now. They've been funded through other programs. So ONC, for example, has given Ocean Alliance Chicago grants to test the FHIR IG. They also have a LEAP awardee, UT Austin, that has been working on this for the past year. The ACL has a social care challenge program and awardees, and they're listed here. And they're all doing different levels of testing. I would say the ONC awardees are doing FHIR, but the ACL challenge teams are primarily just testing the coded concepts and creating proof of concepts of how they will update their systems to be FHIR enabled. But all entities are invited to participate, and many can be observers, but this is a way where you can learn from those that are actually trying to test this in the field and then sign up to pilot. Next slide. Next slide. So we'd like to acknowledge, again, as a data standards project, the value of our work is truly when it's integrated in other areas, right? And we talk about these other areas as integration at the policy level. Of course, you need to have those levers in place, those incentives to ensure that the standards are adopted and used. There's also in payment models. So we've had lots of discussion. I'll show it on the next slide that there's inclusion of social risk screening in payment models. At the program level, we're seeing that as well. We're having lots of discussion. We've been grateful to inform some of the CMS rules at the program level. We also work with our other FHIR accelerators. So Gravity is one of 7 HL7 FHIR accelerators, and there are others that are working on complementary projects, so we work with them closely. At the grants level, we also will highlight that we have examples of the gravity standards being included at the grant level. So as a requirement for you to receive the grant, you have to test or incorporate the standard. At the practice level and innovation, where we want to do more. This is where we are still looking at our partners to help us define a repeatable process for the adoption implementation of social needs data at the practice level, as well as informing new tools in the market for capture, aggregation, and analysis, and most importantly, use of this data. Next slide. So we are grateful that, as I mentioned, we've been incorporated in some areas and have been able to demonstrate the value of our work. I've already spoken about the inclusion in ONC USCDI. In May of this year, we were very excited to see CMS publish their Medicare Advantage Part D final rule for SNPs that includes standardized questions on housing stability, food security, and access to transportation. So this is, and they're also, we know CMS is working on sub-regulatory guidance with the intent to align it to another policy, ONC's USCDI V2. In August this month, we also saw that the IPPS and long-term care hospital final rule includes voluntary screening and identification of patient-level health-related social needs using USCDI V2 classes. So that's a way that if they point to the data classes, they are following what Gravity has developed. And then lastly, we are included as standard as requirements in 3 grant programs right now. ACL, I mentioned, are the ones that will be doing the pilots. ONC, LEAP, and we have UT Austin as the awardee. We also have the Administration for Children and Families, ACF, had their Human Services Interoperability Innovations Grant, and they were the ones that their logo was there. They were started testing with us in at the CMS Connect-a-thon. Next slide. So I also just want, before I wrap up, is to also acknowledge that our work very much aligns to the HHS strategic approach to addressing SDOH to advance health equity. The link is there at the bottom. We're happy to send it through. So HHS published this earlier this summer, and very much we just want, this visual is from their report, that our work is primarily focused on data standards to support health and human services integration. So we are at the middle level right now, but it's really to support the upstream activities, but as well as downstream activities as described in the report. Next slide. And here is the goal. So it's just acknowledging the report. They have 3 overarching goals. Oh, thank you, Martin. And we align specifically to goal 1, which is helping or supporting the building of a robust and interconnected data infrastructure to support care coordination and evidence-based policymaking. Next slide. All right, so I end on how to engage. Next slide. So for those that have not seen this before, I do want to acknowledge the work of ONC over the past 2 years now on developing an SDOH information exchange toolkit. They're in the process of publishing this, but this, and the link is there, where they've hosted a series of learning forums over the spring and summer, really to review these toolkit components. And what this serves as guidance or for entities interested in social care integration, or establishing what we refer to as community information exchanges, right? We know a lot of the health information exchange entities right now. There's a lot of work going on with TEFCA, but then thinking about it with that social care lens. And so the components here, and if you don't, I know it's long, but really emphasizes governance, right? Before you start any of the initiatives, before you start exchanging data, establishing data sharing agreements, really create your governance, ensure that you have buy-in from all entities involved. And most importantly, what you'll see in this toolkit, the value of co-designing any of these activities with those entities that need to be involved. So it's not just the health system and the health plan or the public health and the state agency. You really need to go out and look at all the existing networks or community networks and bring them to the table before you start having requirements or establishing the data sharing agreements. Next slide. So this is just information on us, so they're here for you, and this actually concludes our presentation. It gives us good time for Q&A. I see some have already been teed up, so I'll pause now and hand back to Kate.